is Professor Win Win Kyaw. I'm mainly cardiovascular surgeon, professor and head of department of Yangon General Hospital in Myanmar.
Okay.
First of all, I would like to say thank you very much to Professor Lee and chairman and members of organizing committees because of actually give me a chance to contribute my knowledge and experience during your much higher tone and texture of your scientific conference liver transplant update 2025. In our country, as a cardiovascular surgeon, but I have to be responsible for vascular anastomosis in both liver and renal transplant. There is no proper transplant surgeon there. That's why I have to anastomosis all liver, hepatic artery, as well as renal arteries. That's why I would like to start my topic. As you know, hepatic artery anastomosis is the most important procedure in liver transplant. What is this? It is the connection of the donor hepatic artery to the recipient hepatic artery, ensuring the blood flow. Where's the determining point? Technical determining process in living donor transplant due to smaller arterial size. Because of that, hepatic artery anastomosis plays a crucial role for transplanted liver survival and function. All you know is the hepatic artery anatomy. Hepatic artery measures about 3 to 4 millimeter in diameter in general, mean size around 3 millimeter from 1 to 4 millimeters. Branches of hepatic artery might be small. Numerous variations of hepatic artery can be found. As you know, there's a visual classification. You can see a lot of variations of hepatic artery anatomy. Because of that, hepatic artery anastomosis we have a lot of several challenges. Sometimes donor hepatic stocks might be short, might be branched. The complication of hepatic artery anastomosis following liver transplantation directly impact on post-operative patients' mortality and morbidity. The outcomes are favorable when hepatic artery anastomosis is performed using 7-0 or 8-0 proline with continuous or interrupted suturing techniques. Whatever the techniques totally depends on experienced hands. It should be carried out by experienced hands to give a good outcome. Before studying my topics, I would like to say very few things for junior people like history and apparatus and instruments. History, as you know, vascular anastomosis techniques established in the first decade of the 20th century. There's Alice Carroll, these are Carroll techniques. According to the appropriate instruments and apparatus, actually we use customized loop. This morning, I saw the one paper different between customized loops and surgical microscope. Actually, totally depends on surgeon choice. I loop or such a customized loop, which precise and meticulous anastomosis with its sufficient magnification, but it takes times. All knows this is a traumatized vascular clamps. Among instruments and apparatus, I specially use two materials. One material is personalized vascular probe, which is very soft, very thin, and cylinder, rogue-like device, and available in various sizes, but very, very expensive. I only use in cardiopulmonary bypass, coronary bypass, graft, CABG, and mainly Lima to internal memory artery to LAD. At that time, I use it. Another material, special material, is coronary vascular shunt. You can see various size, 1 millimeter to 3-4 millimeter shunt. Every day, I use this shunt for coronary CABG cases. I would like to say some fundamental steps for general vascular surgeon. First step, before doing anastomosis, all surgeons should know the surgical anatomy and thinking and planning. That's why pre-op mapping and angiogram, CT or MRI, whatever it is, very important to get the ideas. Second things, we have to collect appropriate surgical instruments and sutures, mainly that were country like in Myanmar. In general, we have to explore widely, and proper exposure good enough to see healthy portion of the vessels. And then in general rules, before clamping, we give systemic heparinization and then clamp and anastomosis. Before finishing, we have to check proximal and distal flow. If happy, we close it. Some people needs antiplatelet, some people needs anticoagulant therapy. According to the techniques, we have various techniques, maybe intermittent, interrupted technique, or continuous technique, or single stage, inlet stage, parachute techniques, full current technique, end-to-end, end-to-side, side-to-side. In my technique, I combine parachute technique plus speculation techniques. This is interrupted sutures. This is a continuous suture. This is single stitch method. This is inlay techniques. These techniques every day we use because in Myanmar we have no intervention, evil or devil or intervention. That's why every day we anastomosis, elective abdominal aortic aneurysm or rupture aortic aneurysm. We use open technique at that time. I use this inlay techniques. In our junior people used to be. This is a full quadrant. This is end to side. This is parachute techniques. This is end to side, end to side, end to anastomosis. You can see speculation techniques. I describe it. This is my topic. Before doing my topic, I have to prepare speculation. What is parachute techniques? Parachute technique is a highly effective method for arterial reconstruction, particularly valuable when suturing very small vessel in living donor right lobe transplantation case for anastomosing the donor and recipient right hepatic artery. This precise technique involves repeatedly applying a specific suturing method along the posterior wall of the both vessels, ultimately securing them with the continuous sutures. And then gentle traction is applied to both ends of the suture, perpendicular to the vessel axis, while atraumatic vascular force provide intermittent counter traction along the vessel axis. To secure the anastomosis, both ends of the sutures are pulled simultaneously while the vessel is gently lifted to remove the sludge, thereby parachuting the vessels into place, ensuring the heel is pulled down tightly and creating a secure watertight seal. And to anastomosis, actually. Both ends of the vessels are speculated to avoid compromising the lumen, and then transited in an oblique manner. I use double-ended suture and parachute techniques is applied starting from heel of the one end and toe of the another end, approximately 4 to 5 sutures around and two ends of the sutures are put on with gentle traction to secure posterior anastomosis. After finishing the posterior wall of the suturing, to facilitate the suturing the anterior wall of the anastomosis, at that time, I choose the appropriate side of the coronary shunt and then put into the artery. You can see, put coronary shunt into the artery and then continue the anterior part of the anastomosis, one and another end. Continuing suturing the anterior wall, before finishing the last stitch, few stitches are loosened to remove the shunt and tied. This meticulous combination of steps ensure even tension distribution along the suture, facilitating the parachuting of the vessel wall together for gradual and precise alignment, ultimately achieving a robust and functional arterial connection. This is our team. Last year, Professor Liam Group, they came and they did 2 cases, same trip. This is my team. Following video will demonstrate the end-to-end arterial anastomosis using the parachute plus combination plus speculation techniques. Please show video. This is the second case. After finishing, I prepared the first case. This is second case because very small artery, around about 1.5 millimeter. After ice, I like 1 millimeter. That's why I put the stay first. I'm holding the adventiture only and then make speculation. I hold the only intima. I don't touch intima, just only adventiture only. And then I start toe to heel. I only hold the adventiture only. I put the bursar knife. I remove the bursar knife and then finish the posterior wall part of the anastomosis. Actually, vessel is quite small. That's why I make sure the lumen and then put the shunt. Only 1.5 millimeter shunt. And then I pull the shunt and then continue the anterior part of the anastomosis. I didn't test any intima. I didn't put into the lumen. I hate holding and putting the instrument into the artery lumen. Now I am finishing the anterior part of the anastomosis. Just only pull the shunt. Heel of the recipient. This is the tool of the donor. Left only 2 stitches.
Is this the rear speed? Rear speed?
I skip. Rear speed.
Speed.
Speed up.
Okay.
Okay. Using microsurgical techniques in arterial reconstruction greatly reduce the incidence of hepatic artery anastomosis complication. In Myanmar, all you know, you see posterior wall of the donor hepatic artery and recipient hepatic are brought together by using parachute techniques, and personalized vascular approach is used in very small vessel to facilitate the anastomosis. Coronary shunt is put into the both end of the artery. After continuation of the running suture of the arterial wall, the shunt is removed and checked. Conclusion: hepatic artery thrombosis is a severe complication following living donor liver transplantation that can be fatal if revascularization is not achieved. If we have a chance, It's quite difficult. Second step, very important things. 8. Traumatic highlight dissection in both the donor and recipient ensure healthy vessels. The use of precise and meticulous anastomotic techniques with suitable modification is essential for arterial anastomosis. Hepatic artery complication can be reduced through microsurgical techniques, including the use of surgical loops. Surgeons with extensive experience in microvascular surgery can achieve excellent outcomes. Reducing arterial complication has a direct impact on enhancing patient survival. The technique and technology evaluation are key factors for excellent results in adult recipient of living donor transplantation. Before conclusion, I would like to say something for take-home message. First important thing is the practice of microsurgical techniques and instruments are essential. Appropriate recipient vessel selections and preparation is also important. Minimization of vessel handling and manipulations are crucial. Very important. And then use of modifying instruments and apparatus and meticulous utilization of variation in anastomosis techniques are totally experienced surgeon choice. Above, these are valuable strategies to maximize the chance of success. Thank you very much.